Hello friends, my name is Dr. Durga Krishnan from Chettinad Hospital and Research Institute, Chettinad. Today I am here to discuss you about the obstructive airway diseases. I hope before coming to this lecture you would have the basic idea about the anatomy and physiology of the respiratory system. So we will move on to this topic. In this obstructive airway disease, today I am going to cover these 4 topics of asthma, chronic obstructive pulmonary disease, bronchiectasis and bronchiolitis. So first is asthma, that is bronchial asthma. So what is bronchial asthma? It's a disease which is characterized by episodic airway obstruction and airway hyperresponsiveness, which is accompanied by airway inflammation. And usually the patient presents in this with a history of shortness of breath or chest tightness or dry cough. We will discuss it later. So when we are talking about the bronchial asthma, in the development of bronchial asthma, there are certain exposures or risk factors, maybe in prenatal or childhood or adult period, which predisposes the patient for development of this disease. So this is mostly the allergen exposure in those who is already atopic or that is predisposed atopic patient, in which repeated allergen exposure can lead to development of this disease, or it could be occupational exposure in which either it is immune or irritant things, or it is tobacco or air pollution, certain infections like viral or mycoplasma infections, obesity itself, diet which you are following, you could be allergic to that, or then fungal infections or high intensity exercises in elite people. So these are the risk factors or exposures in our life which can predispose us for the development of bronchial asthma. In this slide, the same thing, like the person who is atopic is those who have the allergy, and then if they have the genetic susceptibility or risk genes, and if they are being exposed to the high risk, what I have described in the previous, in their prenatal or childhood or adult groups, this leads to development of symptoms due to bronchoconstriction, which is further because of the airway hyperresponsiveness along with inflammation and structural change. This sometimes gets treated on its own, or we treat and then it subsides, but then this triggers when it is there repeatedly, then it can lead to increase in the airway hyperresponsiveness, inflammation and structural changes, and recurrent exacerbation. So this is interrelated with each other. Okay, so here you can see this in this graph, this and this are being interrelated with each other. So in bronchial asthma, the most important thing which we have to understand is airway hyperresponsiveness. So what is this airway hyperresponsiveness is the hallmark of asthma. It is defined as the narrowing of the airways on exposure to allergen, which would not have caused the narrowing in a non-affected person, or an access response to an inhaled contents which would not have produced the same response in the non-affected persons. Okay. This usually occurs by the stimulation of the smooth muscles. This smooth muscles affection can be direct or indirect. When it is direct release of the histamine and methacholine, which causes bronchoconstriction, or indirectly certain triggers stimulate the inflammatory cells, and then there could be release of these allergens, and then that leads to bronchoconstriction, mucus secretion, and leads to the development of this asthma. So this airway smooth muscles can contribute to the asthma in 3 ways. First, it is just an hyperresponsiveness to the stimuli. In the second, because of this hyperresponsiveness, as a consequence of this hyperresponsiveness, there is hypertrophy and hyperplasia, which can lead to air wall thickening. And lastly, these airway smooth muscles can produce chemokines and cytokines, which can cause increased mucus production and this bronchial wall thickening, and leads to the disease problem. The factors which are responsible, which are related, first is in the pathogenesis is the thickening of the subepithelial basement membrane. and this thickening is because of the repair type collagen deposition. So there is a collagen and matrix deposition which leads to stiffening of the airways. This leads to stiffening of the airways, and it's difficult in the relaxations, and then mucus projection contribute to the chronic airway inflammation. Second is the airway epithelium itself. Whenever there is a separation of the airway epithelium, there's columnar cells from the basal cells, there is a formation of trophic unit, and this trophic unit secretes a lot of growth factors, which in turn cause bronchospasm and contribute to the and mucus secretion and contribute to the chronic airway inflammation. Vascular proliferation. So this is what is called angiogenesis. These angiogenesis post capillary venules, they secretes a lot of immune mediators, which can lead to bronchospasm and contribute to the airway obstruction. Then airway edema. When this airway edema occurs mainly when the patient is having an acute episode. So whenever the patient is having an acute episode, this produces airway edema, which also contribute to the chronic airway inflammation. Likewise, the goblet cells metaplasia and mucus hypersecretion. What this does is this forms a mucus plugs in the medium-sized bronchioles and airways. Then it goes down to the smaller airways and cause the obstruction of the smaller airways along with secretions and contribute to the chronic inflammation. Neuronal proliferation. So this neurotrophins can lead to neuronal proliferation. This neuronal proliferation supplies to these smooth muscles, which can lead to bronchospasm and mucus secretions. Ultimately, all these things are doing nothing but increasing the chronic airway inflammation, which is the main thing in the development of bronchial asthma. In this inflammation, there are two types, that is type 2 and non-type 2 inflammation. So what is this type 2 inflammation and this non-type 2 inflammation? See, this type 2 inflammation is innate and adaptive, that is, it is inside with the immune system. Causes changes and causes the bronchoconstriction. Why the name is given as type 2? Because it belongs to the type 2, because it is associated with the type 2 subset of the CD4 helper T cell, which in turn produces interleukin 4, 5 and 13. And what is this non-type 2? Non-type 2 is more commonly associated with the severe type of asthma that does not respond to the common anti-inflammatory therapies such as corticosteroids. It may occur in separation or it may occur along with type 2 also. Sometimes in some cases it may be associated with chronic infections, occasionally with the atypical pathogens like mycoplasma. So while going towards the diagnosis, so history and clinical features is one of the most important thing which we have to give importance while diagnosing a case of bronchial asthma. So first most important thing is in the history you have to find out whether the patient is having any allergic history. Allergic history means whether there is a seasonal variation or there is a changes in the environment like humidifying or your exposure to air conditions. All these things, if it is triggering the symptoms. So what are the symptoms which is being triggered? That is the usually it presents as a wheeze or dry cough or chest tightness along with shortness of breath. So these are the symptoms. If these things are triggering these, also you have to take the history of the household history like exposure to pets or molds or occupational exposures or certain hobbies like swimming, all these things, if these are increasing the episodes. If in the history you have the patient gives you the history of the use of inhaled corticosteroids or nebulization, and along with these aggravating factors, these are the important history which you have to take. See, all these bronchial asthma patients are usually atopic and half of them gives you history of allergic rhinitis. So how will you find out whether the patient had allergic rhinitis or not in the past? So the features like pale nasal mucosas, or if there is a presence of nasal polyps during examination, this says the patient is having allergic rhinitis. Usually they have these patients, the most important features on examination and auscultation is the wheeze. It could be inspiratory and expiratory, but it is mainly expiratory. And whenever the patient has an acute episode of asthma, they usually have this acute mainly expiratory wheezes. And then when it goes on increasing, sometimes the patient's this expiratory wheeze goes on increasing, the attack goes on increasing, then usually the patient becomes silent. There is no breath sounds which is being audible. It's a severe form of bronchoconstriction, and that says the patient is having a silent chest, and that is the severest or form of asthmatic attack. Pulmonary function test. This pulmonary function test is one of the most important parameter in diagnosing the bronchial asthma. So what happens is this in this asthma is actually there is reduction in the airway lumen, which produces increased resistance to airflow, which can be detected by expiratory airflow during forced expiratory maneuvers. So, what are things which we are going to see in pulmonary function test is peak expiratory flow rate, forced expiratory volume, and the ratio of forced expiratory volume with forced vital capacity, which is all lower than its normal limit. You can also go with the reversibility testing. So what is this reversibility testing? You will go give some bronchodilators and see whether the patient is having reversal of these volumes or not. So it is defined as reduction of greater than equal to 12% increase in FEV1 and an absolute increase of greater than 200 ml at least 15 minutes after the administration of beta-2 agonist or after several weeks of corticosteroids therapy. If it is there, that's the reversibility testing, and that is the diagnostic for bronchial asthma. Now, in cases where the pulmonary function test, test is not able to diagnose, then you have to go with the other confirmatory testing, that is methacholine. Methacholine, a cholinergic agonist inhaled in increasing concentration, is most commonly used. A provocative dose producing 20% drop in FEV1 is calculated with a value less than equal to 400 microgram. That is indicative of the airway reactivity. Now, the other test we do is the routine test of chest X-ray, ECG to rule out whether there is any cardiac involvement, and other blood investigations and sputum analysis. Other than that, other important adjuvant tests are these three, that is absolute eosinophil count, immunoglobulin E levels, and fraction of exhaled nitric oxide. See, this nitric oxide, fraction of exhaled nitric oxide can be done to assess the eosinophil inflammation related in because of the eosinophils in the airways. If you have done the previous eosinophil counts and if you go with the inhaled corticosteroid therapy, then there can be reduction in this, and you can see that the patient is adherent to the treatment or not with this fraction of exhaled nitric oxide test. While considering treatment for bronchial asthma, we use two tracks, that is track 1 and track 2. First, of course, we have to assess, we have to confirm the diagnosis, then symptoms, how it is occurring, and whether there is any modifiable risk factor on that, whether there is any comorbidities or not, whether the patient is using the correct technique of inhalers and adherent to the treatment or not. So because of this, we have divided it into track 1 and track 2. See, track 1 we use for those patients who are poorly adherent to the treatment. Okay, in this the controller and reliever is the formoterol. Formoterol we use, low dose formoterol we used as a controller and preferred reliever. So we have divided the treatment into step 1, step 2, step 3, step 4 and step 5, of course. Here we consider for step 1 and step 2, we use this controller and preferred reliever as and when needed. In step 2, when the symptoms are more, then you have to use low dose maintenance therapy with this reliever. And in step 4, when the symptoms are much more along with low lung function, then you have to use medium dose maintenance inhaler therapy with this inhaler, that is formoterol. And still you are getting episodes, then you have to use this, along with this you have to use LAMA, and then you have to assess the patient's phenotype and consider for the maintenance therapy. Along with this, you can also use immunomodulators. In the next slide I will show you what are the immunomodulators which we are, or biologics which we are using in the bronchial asthma. Then in track 2 is used for patients who are adherent to the treatment. In this, the controller and alternative reliever is the SABA, that is short acting beta agonist. So in this we have divided into step 1, step 2, step 3 and step 4, step 5. In step 1, the patient is less than that is twice a month. You use as and when needed. You have to use inhaler corticosteroids along with that SABA, or you are using SABA along with it. You are also using at that time you are also using the inhaled corticosteroids. In step 2, when it is more than 4 or 5 days a week, then you have to use low dose maintenance inhaled corticosteroids, and as and when needed you can also use this SABA. Then in step 3 and step 4, you have to use, along with this low dose maintenance inhaled corticosteroids, you have to use long acting beta agonist. In the step 4, you have using medium dosed inhaled corticosteroid therapy along with long acting. And as in the previous first step in track 1, the same we are going to repeat it. Here also we are going to use the muscarinic antagonist, long acting muscarinic antagonist, for if the symptoms are not being controlled. So these are the biologics in asthma, that is immunomodulators, which acts to binds to different immunoglobulin interleukins for its action, that is omalizumab or mepolizumab or reslizumab, benralizumab or dupilumab. Route of administration is subcutaneous or IV. So this was about the bronchial asthma. Now comes to the other is the bronchiectasis. So what is bronchiectasis? Bronchiectasis can be defined as a chronic irreversible destruction and distortion of the airways, mostly because of the inflammation to the mucosal and elastic component of the airways wall or bronchial wall. Okay, so bronchiectasis refers to irreversible airway dilatation that involves the lung in either focal or a diffuse manner. This is focal or diffuse manner, and that classically categorized in cylindrical, tubular, and most commonly tubular. Cylindrical or tubular is the most common type, and then it could be varicose or cystic in nature. Okay, so cylindrical is like this, varicosity, and then there can be formation of small cyst. Okay. So when you say that it is focal or diffuse, this bronchiectasis can occur because of infectious or non-infectious process. When it is focal, it is localized to some part of the lung, and it is usually because of the obstruction. This obstruction can be intrinsic in the airway or extrinsic. When it is extrinsic, it could be because of the lymph node enlargement or some parenchymal tumor which is compressing the airways, or inside the airways also there can be some tumor, or there can be some mucus plugs or foreign bodies which is obstructing this airway and leading to this localized bronchiectasis. Diffuse bronchiectasis involving most of the part of the lungs, and it is usually because of the systemic or infectious process. So when we are dividing it, we can say that the bronchiectasis can occur in the upper lobe or middle or central lobe or in the lower lobe. When it is occurring in the upper lobe, it could be because of cystic fibrosis or tuberculosis. In the upper lobe, it is cystic fibrosis or tuberculosis. In the central, it could be because of cystic fibrosis or because of the aspergillosis or because of congenital tracheobronchomegaly. And the lower part, it is because of childhood infection, repeated aspirations, or could be because of immunodeficiency. The most common clinical presentation in bronchiectasis is productive cough with copious amount of sputum production, which is foul smelling, thick and tenacious. Physical findings frequently include crackles and wheeze on lung auscultation, and some patient bronchiectasis exhibit digital clubbing. All the chest radiograph lack sensitivity, but sometimes we can get a tram track appearance. The tram track appearance is because of the dilated airways, which is indicating dilated airway and which is consistent with the bronchiectasis. Chest CT is more specific and confirmatory as far as this bronchiectasis is concerned. So the CT finding include airway dilatation, which gives a tram track appearance or signet ring sign, or there can be a lack or loss of bronchial tapering also. Along with this bronchial wall thickening in dilated airway, there can be inspissated secretions, that is giving an appearance of tree in bud, or cyst emanating from this bronchial wall, especially pronounced in patients who have cystic bronchiectasis. So here you can see the form in the cystic bronchiectasis, these are formation of the cyst. Here in varicose you can see the tortuosity, and here in the cylindrical you can see the cylindrical pattern of bronchiectasis. Signetric appearance, so this arrow is showing you the signetric appearance. This is nothing but the dilated airways adjacent to the pulmonary artery, which is giving the appearance of a signet ring. This tree in bud appearance, it can occur in all the infectious diseases of the airways, which is because of this mucus plugging and thickening, which gives a tree in bud appearance. So when we are moving to the management of bronchiectasis, the most important, usually you get exacerbation in bronchiectasis is because of the infections related. So you have to give appropriate antibiotics in the patients, and then the antibiotics has to be continued for 7 to 10 days. Sometimes you might need to give it for 2 weeks, that is 14 days. Other therapies are bronchodilator therapies along with mucolytic therapy which helps to bring out the sputum, and also it should be assisted with the chest physiotherapy. Sometimes this repeated infection can cause erosion of these superficial mucosal vessels, which can lead to severe hemoptysis. And when the patient is going for severe hemoptysis, definitely you have to admit the patient in the emergency, have to ventilate the patient, try to stop the bleeding, and also save the other part of the lung. When you are not able to manage with this, then you of course have to go with the bronchial artery embolization. So that was the bronchiectasis. Then we are moving out over the next topic, that is chronic obstructive pulmonary disease. So what is this chronic obstructive pulmonary disease? It is defined as a state characterized by persistent respiratory symptoms and airflow obstruction. It is comprised of 3 things, that is emphysema, chronic bronchitis, and small airway involvement. So what is this emphysema? Emphysema is nothing, there is destruction of the alveoli along with the dilatation of the airways. What is chronic bronchitis? Chronic bronchitis is chronic cough along with the phlegm production, copious amount of phlegm production. And this is small airways, usually there is reduction in the number of small airways along with the narrowing of these small airways. So these are the 3 things which comprises chronic obstructive pulmonary disease in this. So I have just used the term, previously only we used to call it blue blotters and pink puffer. These blue blotters nothing but the chronic bronchitis. Why they are being called as blue blotters is usually there is a hypoxemia, and because of this hypoxemia there is cyanosis and bush discoloration. That's why they will call as blue blotters. The most important symptoms with which the patient with chronic bronchitis presents is chronic productive cough, which is mostly purulent in nature. There can be associated hemoptysis in case when they have infection. Dyspnea is usually mild. The patient have cyanosis due to hypoxemia, giving it a bluish discoloration. Peripheral edema, when the patient has developed signs of right-sided heart failure because of pulmonary artery hypertension. And in the findings you get crackles, wheeze, prolonged expiration, and usually the patients with chronic bronchitis are obese. And as a complications of this chronic bronchitis, you can have secondary polycythemia vera due to hypoxemia and pulmonary hypertension due to reactive vasoconstriction because of hypoxemia. Then emphysema. Emphysema are also known as pink puffers previously. Why they are known as pink puffers? Because they have a gaps in between breathing. So they go for the repeated frequent short breaths, and because of this frequent short breaths, they develop pinkish discoloration of the cheeks and skin of the face, which gives with a pink color. Then that's why they were called as pink puffers. Usually they presents with dyspnea, with only minimal cough. Their minute volume is increased, and then there is a pink skin with pursed lip breathing, cachexia. They usually use accessory muscles for their respiration or breathing, and then there is hyperinflation because of the increase in the airspace. There is hyperinflation, barrel chest. There is decreased breath sounds, and patient usually are tachyapneic, that is increase in the respiratory rate. The COPD is related very much in the history. One of the most important thing is that you have to rule out the tobacco history in these patients and smoking history in this patient. And then usually these people go for the type 2 kind of respiratory failure, which helps us in diagnosing these diseases. And as a complication, you can develop pneumothorax due to bulla formation, or rupture of this bulla can lead to pneumothorax as a complication. Weight loss because of the increased workload of breathing, and then cor pulmonale secondary to chronic pulmonary hypertension. For diagnosing, we use pulmonary function test, and gold criteria for severity of airflow obstruction in COPD. These are the criteria with which using pulmonary function tests we diagnose the COPD. It has been divided into stage 1, stage 2, stage 3 and stage 4, that is mild, moderate, severe and very severe. So the volumes which we use is forced expiratory volume, that is V1, and the ratio of forced expiratory volume in 1 second with forced vital capacity. So this FEV1 by FVC ratio remains constant, that is less than 7. Only this forced expiratory volume you have to predict, you get the predicted value. If it is more than 80%, then suggest the patient is having mild, that is stage 1. If it is less than 80 but more than 50, then it says the patient is having moderate, that is gold stage 2. When it is greater than equal to 30% but less than 50%, it is severe, and it says the patient is having stage 3. And when it is less than 30%, it says the patient is having a very severe stage 4 COPD. Chest X-ray also assists in diagnosis of COPD, mainly emphysema. And when you look at the X-ray, you can see the most important is the lung hyperinflation, increasing in the space, and then there is a flattening of the hemidiaphragms. This diaphragm's dome should be seen like this. So there is a flattening in this dome, hemidiaphragm, and then there can be possible bullous, which you can see. These are the X-ray findings. Along with that, when you take lateral X-ray, you can see a barrel chest because there is widening of the anterior posterior diameter. And also you get a Saber sheath trachea sign, which refers to when you take a coronal section, you can see there will be marked narrowing of the intrathoracic trachea, and when you take a lateral X-ray, sagittal view, there is widening of the trachea, which says the patient is having a Saber sheath sign, which is also one of the diagnostic sign to say patient is having COPD emphysema. Then to diagnose and categorize into severity, we use MMRC. That is, MMRC is nothing but the modified medical research counseling classification of dyspnea in patients with COPD, which ranges from 0 to 4, and CAT, that is COPD assessment test, which ranges from 0 to 40. So if MMRC is greater than equal to 2, it says the patient is having severe disease, or if the patient is having CAT of more than equal to 10, that also says the patient is having a severe COPD. With that, likewise symptom, that is low symptoms high risk or high symptoms high risk, we have divided into A, B, C and D, and accordingly we add the bronchodilators for each of the severity of each group. We add the bronchodilator therapy. So as SABA, that is nothing but short acting beta 2 beta agonist, that is salbutamol. LABA, that is nothing long acting beta 2 beta agonist, that is formoterol. LAMA, long-acting muscarinic antagonist, that is tiotropium. Inhaled corticosteroid, that is fluticasone or budesonide, and oral corticosteroid, that is most commonly we use is methylprednisolone. And we have come to the last, that is bronchiolitis. What is bronchiolitis? It is the inflammation of the smaller airways, that is lower respiratory bronchiole, that is smaller airways. Usually it is secondary to the infection with the respiratory syncytial virus, also with the rhinovirus, parainfluenza or human metavirus or influenza virus. Clinically it is usually commonly occurs in kids less than 2 years of age, often preceded by 1 or 2 day of URI prodrome. Severe fever, cough and respiratory distress like tachypnea, retraction, wheezing, all can be present. As a complication, there can be dehydration, apnea in premature or less than 2 months old, and then aspiration pneumonitis or respiratory failures. Non-severe bronchiolitis, you have to anticipatory guide the patient and then do nasal suctioning and hydration. Severe bronchiolitis, that you can give trial of inhaled bronchodilators, heated, humidified, high flow nasal oxygen therapy, then continuous positive pressure, positive airway pressures or endotracheal intubation if needed. So this completes our 4 topics. In the next 3 slides, I am just going to give certain scenarios to find out what could be the cause. So here it is a 26-year-old female who is a IT worker, works in an air-conditioned office, comes to the OPD with the complaints of cough and rhinitis for 3 days and shortness of breath since today morning. There is no history of fever. The patient is having tachypnea, tachycardia with saturation of slightly lower, that is 94% at room air. And in the examination, you are getting wheeze all over the lung field. So what do you think? So in this, as you see, the allergic, that is patient is having rhinitis and this is being exposure history to the air conditioned office. That is one thing. And then the patient is having increased respiratory rate, and also there is a predominant wheeze in all parts. So this says that the patient is probably having bronchial asthma exacerbation, or it could be allergic asthma exacerbation. What will be the route of administration of drug? See, once you are getting a patient, you can use nebulization or you can use bronchodilators and both inhaled corticosteroids, and if the symptoms are not being responded with this, you can go for the parenteral therapy. In this scenario, a 70-year-old laborer that is who is diabetic but having a known smoker, smokes around 20 cigarettes per day, has presented to the emergency department with a history of or complaint of cough since 3 days followed by breathlessness since morning. And on examination, the patient is having a tachycardia with normal BP and saturation is on the very lower side, that is 88% room air, and respiratory rate of 32, which has to be the normal, has to be in this 15 to 16, that is 32 here. And in the respiratory system examination, bilateral infrascapular, infraaxillary, interscapular inspiratory wheeze is present along with crepitations. And ABG, that is arterial blood gas analysis, showing you that the patient is having type 2 respiratory failure. The most important catchy point is this, but the patient is a chronic smoker and smoking around about 20 cigarettes per day. So what I told you, in COPD, usually you have a chronic smoking history with a patient might have a respiratory failure, usually type 2. So here the most probable diagnosis is COPD emphysema. And this is the third and last scenario in which the 60-year-old female, which is a known patient, had tuberculosis 35 years back. That is, past history is there. The patient has taken treatment for that and being stopped treatment only following the sputum was negative. Now the patient presented to you with a history of cough since 1 week with foul smelling sputum and fever since 5 days and shortness of breath since 3 days. On auscultation, you are getting a heard bilateral infraaxillary inspiratory crepitations on the infraaxillary, infrascapular and interscapular area. So what is the most probable diagnosis? The patient is having a past history of TB with history of foul smelling sputum, which provokes diagnosis towards bronchiectasis. So with this, I am completing my topic, that is obstructive airway disease. References, and thank you so much.